All right, this is my week 10 presentation. We'll be starting off with the FIGO staging system, which is used for gynecological malignancies. These are malignancies of the uterus, the endometrium, the ovarian, the vagina, and the vulva. FIGO stands for International Federation of Gynecological Obstetrics. I apologize if I can't say that. But it is a four-stage system with an addition of letters depending on the extent of the tumor. And it's usually based off mainly of this where the tumor is at and how far it's extended. For example, in the endometrium, you'll have F1, well, you'll have stage 1, and that can be broken down into stage A and stage B, just depending on how far it's extended off into. Histological characteristics of the esophagus, stomach, lung, and bladder, and head and neck. So, for example, the esophagus starts at the back of the mouth and extends down all the way through the thorax into the stomach. So the first 2/3 of it is squamous cell, and that's mainly to do because it is transporting food and deals with a lot of friction. So it needs the type of tissues that can slough off. Towards the stomach, protection from gastric juices is more important. So we mainly see adenocarcinomas in this area. Moving on into the stomach, the main histological type of tissue or malignancy will be adenocarcinoma because it needs protection from the stomach juices. It doesn't want to digest itself. Lung, we see a couple different ones. So first beginning with small cell carcinomas, which is considered oat cells, and then non-small cell, which is broken down into squamous cell, adenocarcinoma, and large cell. And these can be found in different parts of the lung. Also, we sometimes see malignancies of the pleural cavity around the lung, and this is usually due to asbestos. The bladder, the main histological cell type is going to be transitional cells, and this is because the bladder has to expand to accommodate very large quantities and shrink back. So the main type of cell is transitional cell. And head and neck, the main type of histology that we notice is squamous cell carcinoma, and that's due because the head and neck is mainly responsible for the transportation of air, liquids, and foods. But we do sometimes see adenocarcinomas in these areas. X-rays and gamma rays are electromagnetic forms of radiation. Um, they look exactly the same. They have no mass or make completely of waves of energy. The only difference is X-rays are man-made, meaning that we take electrons and hit a target, and the electrons interact with the atoms of that target and create photons, which are X-rays. Gamma rays are naturally produced, and this happens when the nucleus of an atom is unstable, meaning that it has too much energy, and any atom and every atom wants to be stable. So what it will do is release energy from the nucleus in gamma rays. Um, One of the most important things for us to have to perform a treatment is a prescription. This is pretty much the doctor's way of communicating with everyone on the team of what he wants done for this treatment. And in a treatment, you will have total dose, fractionization, dose per fractionization, procrastination, which is the length of the treatment. He may also, in addition, have the fields, the angle of the fields, the type of treatment, whether it be IMRT, 3D conformal, 3D conventional, arc therapy, brachytherapy, and he will have the field sizes. So these are all important for us to verify, and also the MUs for each field. These are very important for us to verify because if any of these are off, then the treatment is not being delivered correctly. Sometimes when we're treating patients, due to the area that we're treating, such as the head and neck, or just due to fatigue, a patient loses their appetite or loses their ability to naturally take in their nutrition. So what can happen is you will have patients that need peritoneal nutrition. This type of nutrition bypasses the GI tract, so we don't put no pressure on the esophagus, the stomach, to digest these nutritions and go straight into the bloodstream. This has to be calculated very correctly to make sure that the patient is getting all the nutrients they need, such as certain vitamins and certain macronutrients. T-cell lymphoma is a form of non-Hodgkin's lymphoma. This type of lymphoma has an unpredictable form of spread and is formed from the T cells. T cells are white blood cells that fight infection, so you realize that if they're having mutations in these forms, they are more susceptible to infections. So it's very important that every morning, every month, and yearly that certain quality assurance tests are done. Quality assurance makes sure that the machine is running correctly, and so that way it can deliver dose correctly. Quality assurances are done on outputs, they're done on field size, they're done on optical distance. Also, quality assurance is done on imaging. These are usually performed by the therapist daily on certain ones, and by the physicist monthly. And we work in tandem. If something's wrong, we need to report it. There are tolerances that need to be checked daily, and these tolerances are even tighter when they're checked monthly. Optical distance check is done by the therapist daily and by the physicist monthly. And this is done by when we do our QA boxes and we have to set it to 100 SSD. If our QA readings are off, we start to check everything, such as is the box lining up, is we at the right SSD. And as we're checking these things, if we notice that something is off, we check the field size first. Field size is perfect, we check the SSD, and the SSD is saying that it's perfect, but something's still wrong. Then the physicist comes in with this tool that connects to the gantry and extends down, and it's pretty much a stick with a little point on the end, and that will help us realize if the ODI is off or not. And the importance of this is, if your ODI is off, that means you're treating to the wrong depth, and that means you could be completely missing the tumor and irradiating healthy tissues. And the tumor could be underdosed and healthy tissue could be overdosed, and that is a big issue. We always track every day for our electron outputs. Each energy of electron, each energy of electron has a different dose depth, and that needs to be checked, because if we're treating with a 12 MeV and we want to treat to the 90 isodose line, that dose is about 3 centimeters. But if that output is off, we could be treating 2 centimeters, or we could be treating past that, we could be treating 5 centimeters, meaning that we're missing the tumor. So these the output is checked daily, because our understanding of electrons is based off of the energy dictates the depth to what we can actually treat. So all over the body is lymph nodes. These lymph nodes help the flow of liquids in the tissue. For the breast, the main important ones are going to be the inframammary nodes, which line the sternum, the axillary nodes, which go from about bottom of the breast towards lateral edges all the way up into the armpit, which are called axillary, and the transpectoral nodes. These nodes come across the top, are close to are under this clavicle, but drain into the supraclav. It's one of the reasons we treat the supraclav if we have positive lymph nodes. Earlier we talked about nutrition. So another way that we can get a patient nutrition if they're having issues with swallowing is a PEG tube. And a PEG tube is inserted through the abdomen directly into the stomach. It's important that we know if a person has a PEG tube to make sure that it isn't kinked and we don't bother it in any way. Hypofractionated versus hyperfractionated. So fractionation is taking a large dose and breaking it down into smaller doses. And the reason we do that is to give the body time to repair itself from sublethal damage and gives the tumor time to reoxygenate itself, which is a sensitizer. Hypofractionated, we see this in forms of the Canadian breast method, and pretty much hypofractionation is shortening the fractions, having less fractions, and a little bit of a higher dose. Your total dose will actually be lower, but this is great because we can get as many doses in as we can before we see side effects. Hyperfractionated is another form, and it's kind of the opposite. We're keeping pretty much the same total dose as the standard fractionation, but what we're actually doing is splitting the fractionations into smaller fractionations. So, for example, if a patient's standard dose is 180 centigrades per fraction, we might split that into 2 and do 90-90. This is great because it allows even more time for repairing of healthy tissues and oxygenation of the tumor. So small cell lung cancer is one of the most aggressive forms of lung cancer, and most of the time, by the time we even realize a patient has it, we believe there's brain mets, and it travels to the brain quickly. And due to that, we actually irradiate the brain, and that is called prophylactic cranial irradiation. And you do about 2,500 centigrades in 10 fractions. So the hypopharynx is about at the level of your, I'm thinking of the bone, the codochord cartilage, and this area is about here in the throat. And the superior border is the edge of the mandible and the mastoid tip, the thyroid cartilage. That's what I was thinking of. But the thyroid cartilage and then the corticosteroid. It just depends on the tumor extension in the sense of the posterior portion of this field, but if you have negative margins, it's the front of the vertebral body. If you have positive margins, it's the posterior end of the vertebral body. The inferior border is the corticosteroid cartilage. Orthostatic hypotension. This happens anytime a person goes from laying flat to sitting up or standing up, their blood pressure drops. This is very important because they can become dizzy, they can easily fall. So if we have patients that suffer from this, it's important that we help them get up slowly, stay near them, and monitor them to make sure that before they stand up on their feet, that they are okay and that their blood pressure hasn't dropped. And even after they stand up, I think it's important to, with patients like this, walk with them. Just take the extra time to walk them up front, make sure another person's eyes is on them before you let them go. Because the last thing you want is they turn the corner and drop and no one's there. Dysphagia is difficulties producing speech. This can be due to brain lesions or in the cerebral hemisphere, and this can also be due to swelling of the brain. So anytime you have a patient and they're trying to say something and you can't understand them clearly, and sometimes, it can be for plenty of reasons. We all speak different languages. We all are from different regions of America, so our pronunciation of certain words could be different. But you need to be aware if you're starting to see someone just trying to say something and it's not coming off at all, you need to talk to the nurses. You need to tell the doctors. They need to know about this immediately because If there is swelling of the brain, this can be dangerous. Because of the skull, there is not a lot of space for swelling to be able to push out, and pressure in the brain can be dangerous. Ileostomy, I can't say the word, and coleostomy are pretty much when we need to bypass the rectum for many different reasons. So what will happen is a stoma will be opened and connected from the outside of the body for the ileostomy. This is connected directly into the small intestines to help with defecation. I was thinking digestion, but it's defecation. And the coleostomy is actually connected into the large bowels. This is important because if a person can't get rid of their excrements, this can lead to sepsis. Uh, I am horrible at pronunciations, but a chondrosarcoma is pretty much malignancies of the cartilage, and they're usually about 4 centimeters long and have a bluish gray or white cut due to the presence of hyaline tissue, which is a form of cartilage. Multiple myelomas. This is always tough because it happens in young people, and in real ways, radiation is just palliative in this type of treatment. This arises in the bone marrow, but most commonly resides in the area of the spine, pelvis, and skull. It most commonly arises in the first rib, and the group mostly affected by this is African Americans. This is always tough to watch, man, because you see it all over their body. After first diagnosis, if caught early, a person doesn't really need treatment for about the first year to 3 years, and chemotherapy is the best form of treatment for this. In clinic, I've seen it in a lot of young people, and it's tough. It's tough. So benign tumors are tumors that are encapsulated, they're small, not aggressive, and aren't currently growing. But that doesn't mean they can't become malignant or cancerous. Places we normally see this is anal polyps, and what happens is, at first they're perfectly fine, but due to irritation and continuous growth, they open up and become malignant because they start to spread. And even though a benign tumor is not cancerous, it can cause issues depending on its size and location. So if it's in a bad spot and it's grown too big, it can cause obstructions, and constant irritation can lead it from benign into malignant. Back to quality assurances. I love QAs. I come in every morning for QAs. I think it's a great way to get comfortable with the machine, get comfortable lining up. QAs are super important, and the reason for it is you want to know that your machine is working exactly the way it needs to work. You know what I mean? Because if it's not, that means every time you turn that machine on, it could be doing something different. And that's a mistreatment. And it has to be adjusted for temperature, pressure, and humidity. And the reason for this is radiation interacts with everything. If it's an atom, it comes in contact to it, it interacts, and this can cause additional scattering. This can lower the dose. This can cause additional attenuation. So quality assurances are done every morning to make sure that imaging is correct, output is correct, ODI is correct, and if not, there's a tolerance, and if we're within that tolerance, we can still treat that day. But people need to be informed. And if it's way out of that tolerance, which is a 2% tolerance, if it's way out of that tolerance, then we got to stop. We got to shut it down, because at the end of the day, you're mistreating. And mistreating is not acceptable. DNA synthesis is pretty much when the DNA within a cell breaks down to replicate itself to create a new cell. And this happens in mitosis and meiosis. This is also the most radioresistance part of the cell cycle. And the reason for this is because this is when the cell can repair itself if there is damage. And if it can't repair itself, it'll kill itself, which is better than it becoming malignant. So this is one of the reasons it's most radio-resistant part of the cell cycle. Honestly, when we're irradiating, if we could, we would love for healthy tissues to be in synthesis and cancer cells to not be. Lymphatic drainage in the head and neck, thorax, pelvis, and bladder. Whew, that's a lot. So the head and neck is broken down into the oral cavity, nasal, oropharynx, hypopharynx, and larynx. So for the oral cavity, the Burkinator node, the jugulogastric node, mandibular, and submental, just depending on where that tumor is. So if it's towards the front, it's going to be the submantle into the submandibular, and then it's going to drain into the cervical nodes and jugulogastric. But if we're dealing with the nasal pharynx, it's going to first go into the cervical, retroperitoneal, then jugulogastric. Oropharynx is the subdigastric, upper cervical, submaxillary pharyngeal. Hypopharynx is mid-cervical, jugular, and retropharyngeal. And larynx is jugular, gastric, jugular, and paratracheal, and pretracheal and paratracheal. For the thorax should be broken down into the breast, the lungs, and esophagus. So for the breast, it's inframammary, subclavicular, transpectoral, and axillary. Lungs is the hilary, mediastinal, bronchial, paratracheal, interlobe, and I said mediastinal already. So the esophagus is a long tube that runs from the back of the neck, that starts at the larynx all the way down to the stomach. So its nodes are jugular, cervical, paraesophageal, supraclav, hilary, subcarina, pericardial, celiac, and gastric. Because it runs so deep down, it can drain to any of those. The pelvis is broken down for most people into the anus, the rectum, the bladder for men, the prostate. So the anus is the pararectal, anorectal, internal iliac, sacral. The rectum is the rectal, internal iliac, para-aortic, inferior mesogastric. Prostate is the operating node, external iliac, paraprostatic, hypogastric, common iliac, and para-aortic. Just a lot of science words that I'm just horrible. I know where they're at, but I'm just horrible at them. For the bladder, it's the sternal iliac, common iliac, and presacral and para-aortic. Whew, it's a lot. Ooh, the belly board. You don't see it a lot, and I wish you did see it more. And I know for therapists it's a headache of a setup, but I think for patients it's amazing because it's so hard. So first of all, a belly board is used to displace small bowels. And one of the reasons it's so important to displace the small bowels is the small bowels aren't really like attached to a bone, so they constantly move. So we don't want to irradiate them because if you get a tumor in the small bowels, all they can do is cut it. They can't. It's so hard to keep it in the same place if we wanted to treat it. So the belly board, pretty much a patient lays down, and there's a section that opens up to allow their stomach or their abdomen to fill in, and this helps to displace the small bowel. The reason it can be used is if a patient has issues filling up their bladder, which is another way to displace the small bowels, but that could be difficult in getting consistency, and I've seen that in clinic before. Whew. So match lines and couch kicks in a multi-ISO breast treatment. The reason for this is when we treat a breast, we usually treat it with a tangent, and beams diverge. So what can happen when beams are diverging and crossing, it can create hot spots, and we don't want a hot spot unless we're using that to our advantage in treating a certain area. So what we can do is turn our collimator to line our tangent divergence, because the top part of the beam is going to be diverging. That's going to be diverging in air. We don't worry about that. But inside the body, we would prefer a straight line instead of this, because when you're treating the breast, the heart and lungs are also there. and we don't want too much dose to that area. So by turning our collimators just a little bit, we can get a perfect line. Also, another area with divergence problem is the superclave, which is this area up here. And we can get our tangents to look pretty nice, but with the superclave, we can either do a couch kick or a half beam block to make it a straight edge, and that way we can control our hot spots. You don't see this too much in treatment anymore because most breasts are treated with one ISO instead of multiple ISOs. And another headache that you see in this, if it does have multiple ISOs, is match lining. You have to pretty much go in there, make sure you document where that line is, so when you switch them from the breast ISO to the superclave ISO, that line matches up. Because again, you can create hotspots, and hotspots can lead to all types of problems, such as overdosing, necrosis, quicker side effects because they're getting dosed from both fields, and that can be an issue. Applications of CT images. So pretty much when I saw this, I thought the protocols. For example, when you're using the CT imager in CT, or when you're using a cone beam on a treatment table, we pick certain protocols so that way the machine understands what type of densities it's going to deal with in the body. So for example, if you don't pick the right protocol on a cone beam and you do an extremity, which is usually a lot thinner than a thorax, if you go to CT that thorax, you're not going to get a good contrast in the sense of bones to tissue, which can become a headache. Not a cone beam, my fault. Even with KB images, you see this. But these are important because we want to make sure that we can see what we need to see. And when you're using a LoRa, you don't want to be cone beaming or KVing a person over and over. So we pick what type of protocols we want for the body parts that we're picking. So for a pelvis that is super thick with multiple bones in it, we want to let CT know that, hey, you're going to be running into this. So be prepared, and these protocols help us with that. Supravena cava syndrome. You see this sometimes with tumors of the thorax, tumors in the lungs, tumors in the esophagus. What happens is your supravena cava is the biggest vein in your body. All your veins run into this to bring blood back to the heart. So anytime there's a tumor in this area, it can press against the supravena cava, and that can constrict blood flow. And you will see people that have this issue. This is a medical emergency, meaning that we need to treat this immediately. Sometimes calcs are done on the spot, and the fields are 3D conventional. They're open fields, and we're blasting it to make sure that we can get this tumor to shrink, so that way this person doesn't pretty much suffocate due to their blood not just circulating quick enough, not getting back to the heart to get oxygen. So when we see this, we see swelling of the face, shortness of breath, swelling in the arms and hands, distended chest veins, hoarse voice, and difficulty swallowing. And they even get lightheaded pretty quick. Again, medical emergency. I'm so sorry, guys. I'm so sorry. I'm just horrible with words. Doxorubicin or mitomycin. This is a chemotherapy drug, and it's used in a lot of chemotherapy sets. And the main thing we need to know about this, it can cause cardiotoxicity, but it also could be used as a radiosensitizer. Little fact. It's used in breast cancer treatments, ovarian treatments, and bladder treatments. Bleomycin, see, I know how to say that one. I got y'all. It's used in the treatments of lymphoma, ovarian cancers, testicular cancer, and cervical cancer. This chemotherapy drug can cause pulmonary toxicity. An alternate name for it, which I'm going to butcher, is bleozinase. We're just going to get past that. Don't even grade that part. Okay, I didn't change this in my thing, but I did figure it out. Pretty much it's the inverse square law. We can figure out based on depth, based on the distance So if a person was supposed to be treated, for example, at 100 SSD, but they're treated at 102, they're further away from the source. And that means that they were underdosed in that moment. And we can figure that out by doing our inverse square, using the distance of the two distances and using what was supposed to be their dose at the 100 to figure that out. I apologize, I didn't even know. I thought I changed this, but soft tissue sarcomas. These are rare, but these are pretty much malignancies of muscle, cartilage, fat, pretty much not our normal epithelial tissues. So for fat, it's a liposarcoma. For connective tissues, a fibrosarcoma. For nerves, it's a neurofibrosarcoma. For blood vessels, an angiosarcoma. And for skin, muscles of that are under the skin, are carpiosarcomas. These tissues are radio-resistant, and that is because muscles are usually fixed. They aren't tissues that are dividing all the time, and these things can get pretty raunchy. So latent and prodromal stages are a part of acute radiation syndromes. So hepoetic, gastric, and central nervous system. So the prodromal state is the first state. This happens immediately after exposure. Within a couple hours to a couple days, a person can be they can be vomiting, diarrhea, headache, increase in body temperature, and then they go into the latent stage. And this is kind of scary because the person seems perfectly fine. They're not showing any effects. They think they're okay. They think they got better. And the crazy thing is radiation has no smell, taste. It's not visual. So a person can be in latent stage, prodromal stage, thinking, man, I'm just feeling horrible today. I'm horrible. And they go home, I'm better. And then the manifest stage happens. And most people don't survive acute radiation syndrome except for hepoetic. Exposure in air is measured in Roentgens. This is pretty much ionization of air. We use this to understand how radiation is reacting in air. Things like temperature, pressure, and humidity affect this. And it pretty much just hits air and creates ion pairs, and we can measure the ion pairs. We use this type of idea with ion chambers, and there's two inside of the LINAC. Flattening filter. So I spoke about this during flatness and symmetry in week 9 presentation. When electrons hit a target, especially high-powered electrons, the radiation field is actually going to be pointed. And the problem with that is you're not getting an even distribution of the radiation in that field. So what we use is we slide in this flattening filter, which helps change the field from a dart into more of a uniformed flatness. And the flattening filter is between the first and second collimators. The purpose is to flatten out the beam and create a uniform dose across the whole field. And it's only used in photon treatments. You wouldn't use it in electron treatments because electrons come out as a straight little dot of lines. So inside of our treatment head is the bending magnets, the target, the primary collimator, flattening filter, and scattering foil, 2 ion chambers, MLCs, lower jaws, and the secondary collimator. TAR, tissue to air ratio, is the dose. So pretty much this is, I'm trying to make sure I remember this correctly. I want to say it is the dose in air divided by, my fault, I gotta make sure. TAR is the dose in tissue divided by the dose in air. I was about to get that wrong. This helps with calculations when transferring treatment dose to the MUs. It's important to know how radiation will react in air, water, and tissue.